New topic, Couvelaire uterus. It is known as uteroplacental apoplexy, pathological condition where there is extensive extravasation of blood into the myometrium due to a severe form of abruptio placenta. The uterus appears bruised, ecchymosed, and may have areas of necrosis due to impaired blood supply. Despite its alarming appearance, it is not an indication for hysterectomy unless associated with intractable postpartum hemorrhage. Yeah, so let's look at an image so that we are clear with what it is. This one should be good. Yeah, here you can see how the uterus looks like. It's very much red, ecchymosed, and why is it? Because it is the blood is in the myometrium and it is secondary to abruptio placentae. So here is another image showing the exact same thing where the blood is over here and it is infiltrating the myometrium, but it is secondary to abruptio placentae. That is what we need to keep in mind. Coming to the pathophysiology, it is due to placental abruption. Maternal blood collects between the decidua basalis and myometrium. This leads to disruption of the muscle fibers, hemorrhage into the uterine wall, and infarction. Makes sense. The myometrium appears dark bluish or purple, port wine color due to diffuse extravasation of blood. Blood may track into the broad ligament, peritoneal cavity, and serosal coat of the uterus. So it may track into the broad ligament, peritoneal cavity, serosal coat of the uterus. So not just this thing between the decidua basalis and myometrium, but also the broad ligament, peritoneal cavity, and serosal coat. In severe cases, coagulopathy may develop leading to DIC. So that was the pathophysiology. Coming to clinical features. Seen in severe cases of abruptio placenta, we have seen it already, always associated with abruptio placentae. Uterus is tense. So now the features of abruptio placenta. Uterus is tense and does not relax with between the concentrations. Concealed hemorrhage leads to shock and disproportionate to visible blood loss. Even this was a feature of abruptio placentae. Features of hypovolemia such as tachycardia, hypotension, pallor. It was not mentioned earlier, but these are the features of shock. DIC may develop leading to bleeding tendencies, and uterus may remain atonic postpartum, increasing the risk of postpartum hemorrhage. So these are the clinical features, and which more or less make sense, all of them. Coming to the diagnosis, clinical suspicion seen in severe abruptio placenta with disproportionate shock, so more than expected. Ultrasound may show retroplacental hematoma and abnormal echogenicity in myometrium. So let's look at this retroplacental hematoma on a USG so that we are much more clear at how it looks like. So here they have mentioned it, maybe this is the one, retroplacental hematoma. Yeah, maybe this is the one. This is the one they have marked. So probably this is the placenta and retroplacental beyond the placenta, and here it is the uterus probably. So this is the retroplacental. Placenta is anterior and clear of the os, hypogenic region within the posterior aspect of placenta. So is it hypogenic? Abnormal echogenicity. So probably hypogenic. This is fine. MRI can detect intramyometrial hematomas, within the myometrium. Coming to laparotomy or caesarean section, uterus is port wine colored, ecchymosed, diffuse hemorrhage into the myometrium, broad ligament hematomas, and uterus may remain atonic even after delivery. This has been repeated twice, so better to keep in mind. Complications: PPH due to uterine atony, again PPH, which is one of the most very scary situation. So there is a section on it altogether, atonic PPH. Anyways, coming back, DIC hypovolemic shock, renal failure, acute-tubular necrosis due to hypotension, that is the cause. MODS, multiple organ dysfunction, not MODS, just MOD, multiple organ dysfunction, severe cases, maternal mortality if not aggressively managed. Coming to the management, we have few points. One is immediate resuscitation, delivery of baby, PPH prevention, correction of coagulopathy, ICU, intensive care, monitoring. So first one, immediate resuscitation, ABC, IV fluids, blood transfusion, oxygen therapy. First one, secure airway, breathing and circulation, crystalloids and colloids for volume resuscitation. For blood transfusion, packed RBCs, FFP and platelets if needed, oxygen therapy to prevent hypoxia. Coming to cesarean section, coming to delivery, cesarean section is required. Vaginal delivery may be possible if fetus is dead and maternal condition is stable. So only in this particular condition we go for vaginal delivery. Let's get some understanding as to why this is the case. Why in Couvelaire? I don't know the spelling, that's the issue. Maybe this is the spelling. Hopefully this is the spelling. Couve. Yeah, thank God. Yeah, it's possible. Uterus occurs in severe placenta abruption. Why that is the case? Yes. Okay, that avoids. Okay, so it is mainly seen as an invasive method of dealing with things due to severe uterine atony, okay, difficult hemostasis and possible hysterectomy. So yeah, something. Maybe I need to save it. I'll just save it just in case you would like to go through it. So it mentions to avoid excessive bleeding secondary to C-section, probably because it's an invasive where you do incisions and all that. Yeah, so done. Yeah, next coming to, where is it? Yeah, active management of third stage to prevent uterine atony. So we know it, we are not going back. Coming to PPH prevention, oxytocin, which is oxytocin, ergometrin, misoprostol, we have seen this already. B-Lynch suture, uterine compression sutures in case of atony. Let's take a look. B-Lynch suture. Okay, so here they are doing something where they are passing this like this, then like this and like this, and overall they are tightening it. Probably they are tightening it very nicely. Compression, yes, compressing it in case of atony, uterine artery embolization in case bleeding occurs, and hysterectomy if it is uncontrollable. Coming to correction of coagulopathy, DIC management, FFP, cryoprecipitate, platelets, monitoring coagulation profile frequently. So these two things. Then that is for coagulopathy. Next, coming to intensive care monitoring, urine output monitoring to assess renal function, because hypovolemia is happening, is the case in this particular issue. Hypodynamic stabilization if in ICU if required, multidisciplinary approach, obstetrician, anesthetist, hematologist and ICU team. So these were the management points. Coming to the prognosis, if it is promptly managed, maternal survival rates are high. Untreated cases may lead to maternal mortality due to hemorrhage or multi-organ failure. So this is all about the topic Couvelaire uterus. In case you like this particular video, you can like it. In case you would like to watch more of such videos, you can subscribe. In case you would like to say something, discuss something, any suggestions, you are free to do so. Yes, bye bye.